Hello, hello, everyone. Happy Thursday. Welcome to another VMR. Today, we get one of our interns back in the discussion seat, which I'm very, very excited about. But before I tell you who that mystery person is, and hint, it's not a mystery because you see her all the time on Mondays, I'd like to extend a big round of gratitude to the people who are making this happen, beginning with Rahul. Rahul, do you want to say hello?
Hi, Rabih. Hi, everybody. Good morning, good evening, good afternoon. And I'm very, very excited for the Kirtan's case and very excited for the discussion today. Thank you.
Thank you, Rahul, for the hard work in scribing. And I know Patricia is doing teaching points today. Patricia, I'll hand the mic to you to say hello.
Hello, everyone. I'm Patricia. I'm Ju from Cameroon, and I'm excited about the case today. Can't wait for your discussion.
Amazing. Last but not least, we have our case presenter, the one and only Dr. Kirtan Putolia. You want to say hello, Kirtan?
Hi, good morning, friends. Thanks for joining on this VMR. I'm excited for presenting today's case. It has been a while since I presented. Last I presented was on Christmas. So finally, I got some time to present, and I'm sure we will learn a lot together.
I think every day you present should become a federally recognized holiday, Kirtan, so all of us can take the day to reflect on the poetry you bring us. So thank you so much for coming, and thank you so much for your case, and we hope you live on VMR. Somebody who has been living on VMR despite a very busy intern year is our case discussant today, Hui Ting, and some of you may not know her because she is a very busy, hardworking intern, often in the ICU. But she has been part of CP Solvers for over a year now, doing incredible things. And I think it really is very telling to see how dedicated somebody is to the mission of clinical reasoning and democratizing it when, despite being so busy, you see her not infrequently on subspecialty VMR. I and others see her every week putting in hard work, putting the infographic together, and sometimes even reminding people to jump in and do scribing and teaching points. So very, very excited to celebrate all your passion and love for clinical reasoning today, Hui Ting, and I'll pass the mic to you to say hello, and then we can we can tumble through a kirtan case together.
Hi everyone. Yeah, thank you so much for having me back. I feel a little bit out of shape as well, because it's been a while since I discussed a case, but I always feel very humble to be here on the morning report because it's so much learning, and of course, we always among friends. So I'm very excited for today's case, and yeah, I hope we get a lot of fun and learning.
Oh, that we will indeed. All right, Kirtan, take it away.
Perfect. All right, friends. So the title is the transducing diagnosis. So I will combine first and second record. So I will give all the data till the physical examination. So we have a 63-year-old pleasant lady who is presenting with 1 week of fevers, chills, fatigue, headaches, sore throat, and productive cough. Over the last 2 days, she started experiencing left upper quadrant pain, which was most pronounced on coughing. She denies prior similar symptoms, photophobia, neck stiffness, blurry vision, any hearing changes, no chest pain, dyspnea, no diarrhea, constipation, no hematuria, hematochezia, or rash. So all of these things have been going on for 1 week and basically started to go downhill in last 2 days. In the ED, you see her and the patient was febrile at 38.2 degrees Celsius, tachycardic 210 beats per minute. She was not tachypneic and saturating well on room air. Giving you some past medical history, so she has seropositive rheumatoid arthritis, and she has been on multiple medications over past 5 years, but most recently she has been on adalimumab, which is one of the TNF alpha inhibitors. And the way it is dosed is either you take it once a week or you take it once every 2 weeks. So last time she took this adalimumab was 2 weeks ago, and she has been on adalimumab for last 6 months, and her RA has been well controlled on this regimen. Her other relevant history is that she has childhood TB with bronchiectasis in upper lobes and calcified granulomas in different parts of the lungs. And she was treated with tuberculosis 10 years ago. And last AFB sputum cultures and PCR, which was obtained in 2017, was negative. She denies recent travels, no smoking, no alcohol, no other drugs, no pets or sick contacts at home. You see her and you find that she looks unwell, and you can clearly see that she's maybe conversing not entirely clearly. She's not confused, but you can say that she is not very coherent in her conversation. You auscultate her chest and you find that in the upper lung fields there are reduced breath sounds bilaterally. And on abdominal examination, you find tenderness in the left upper quadrant. And that's the end of the cell.
Wow, Kirtan, this is absolutely amazing. And wait, this is now your reality, right? You often get sign out from emergency room with all this information. So if this were a case in real life, I'm curious, what questions would be crossing your mind to maybe ask the person on the phone about this case? What are your mind doing?
Yeah, I mean, as an intern, I think often I change the perspective when it comes to like clinical reasoning because it's not so much on paper or textbook anymore because we get a call and usually we don't get the patient with all the, the textbook symptoms. And sometimes we have a patient in the ED who came with some altermentation. And we can ask any questions, and sometimes they don't give us a very straightforward answer, and it's up to us to find all the pertinent answer to our question. Sometimes we have to reach out to the POA, the family, and just really get a really good history of this patient present illness. So with her, actually, I will ask a little bit more about like what is the time of the presentation and why what's the big reason for her to come here today to the ED because it's been going on for a couple of days, some non-specific symptoms, and can be a lot of reasons, because even starting with the fever and headaches, sore throat, it's very non-specific. And for example, for the fever, I would kind of ask about taking in consideration the mnemonic, the I made mnemonic, and find out the different causes. For example, I stand for infection, so I kind of want to see if there's underlying infection in this case, if it's something upper respiratory infection with abdominal pain, if there are any gastrointestinal infection that we can rule out. And with M stand for malignancy, which is her age. I'm not gonna jump into conclusion any type of malignancy at this point, but it's also something that I gonna take in the back of my mind as well. And autoimmune causes, she already have history of autoimmune diseases, so it's not uncommon that it coexist other type of autoimmune condition for this patient. Um, and the other, for them, I made mnemonic, we have D, which is stand for drugs. Somebody who is 63 years old, we always try to see if there's some kind of polypharmacy, which is very common, more than we think. The patient come here with polypharmacy, and the last one, which is E, stand for endocrine causes. So it's like well, at this point, I think there is like very non-specific symptom at this point, and I was just gonna like ask more like when did it started, the timeline, and what like actually make you come to the ED, which is very important because there is so many different symptoms that I want to know which one is the one that brought the patient here to the ED.
Yeah, no, I love that. I love that you focused on the fever as the place to generate a differential diagnosis. And if you take the patient's word for it, which you should be careful of, and make sure it really is acute, 1 week duration, then I think the main focus is on infection, especially in an immunosuppressed host. And so, as you said, the question becomes, well, where is this infection? And you're right that many of her symptoms don't give you specific guidance on the location of the infection, with headaches and sore throat and cough being fairly non-specific, especially in relation to left upper quadrant pain, which is a very, very specific symptom complex. And unlike those other non-specific symptoms, often is indicative of where the disease is. And so in most people with left upper quadrant pain in general, without the fever, their discomfort is often gastric in origin or pancreatic in origin. But when you overlay left upper quadrant pain with inflammation, you realize that the stomach and the pancreas are rarely involved in systemic inflammatory diseases, and that's where the spleen comes into consideration. That's, of course, with the assumption that left upper quadrant pain is in the abdomen. Left upper quadrant pain could represent a pleural pulmonary focus of disease, especially in a patient who's coughing. So I think for me, I'm really curious to see if she has disease in the left lower lobe of her lung, her pleura, or her spleen. And if I used the pulmonary exam as a clue, with the lower lobes being relatively spared of this disease process, I'm more and more worried about an acute inflammatory syndrome involving the spleen. And if that is an early hypothesis that we have, we really have to pursue it very quickly, because the possibility of disease going to the spleen often means very bad things for the patient, including the risk of acute myeloid leukemia, the risk of endocarditis, and the risk in a patient with RA of a very hectic autoimmune disease related to RA and spleen called Felty syndrome. So realistically speaking, I'm right there with you. This is infection in immunosuppressed hosts until proven otherwise, who has a wide variety of non-specific symptoms. But one early hypothesis is left upper quadrant pain invoking splenic involvement owing to the fever. And so I would pursue that hypothesis with a great degree of fervor. Now, you know the reality of this. It's going to be a little while before we have a result of a CT scan to tell us what's happening to the spleen. And this is where, when you're thinking about the spleen, you realize that the spleen is a hematological organ, and often the CBC gives you a lot of clues as to what's happening in the spleen. And if you remember Kirtan's last case of a patient who had splenic disease, who had neutrophilia, that combination of things was virtually diagnostic of Simi's favorite disease, Still's disease. Um, Now we'll have to pay attention to the CBC and see what clues that gives us, and try to merge that with a possible hypothesis of the spleen. So, yeah, really, really good thoughts, and excited to see where Kirtan takes us next.
Perfect. Friends, you are on the right path. And now I will give you some basic labs before I share the imaging in next record. So patient's hemoglobin level was 10.7. Last time it was 11.8. WBC was 1.7. Last time it was 8.4. And absolute neutrophil count is 300. Platelets are 145. Last time it was 196. And I can tell you the labs, how it evolved over the course of 1 week while patient was in the hospital. So baseline hemoglobin was 11.8. Then it went up and down, and finally it stabilized at the baseline at the 1 week mark. So it was again 11.8. WBC, it was 1.7 on admission, but then again it also went up and down, and it was 3.9 on the day of discharge. And platelet counts was 145 on admission, but on the day of discharge, it was 180. BMP was within the normal limits. Total protein 6, albumin 3.2, liver enzymes including AST, ALT, alkaline phosphatase, GGT, and bilirubin within the normal limits. LDH was elevated at 300. You obtained some inflammatory markers. So ESR was 140, CRP was 40, ferritin was 3000, vitamin B12 levels elevated at 1200. Coagulation, so INR normal at 1.2, but APTT was elevated at 50, and fibrinogen within the normal limits. And that's the end of the study.
Fascinating. What stood out to you from the Saliqua?
I'm very interested. I mean, the CBC, just CNN, there is, I think, the pancytopenia for this patient. And another thing that is cutting my attention is the ANC of 300. So I was wondering where is that neutropenia coming from? If this is infectious process going on, or something more autoimmune causes. And I think the other thing that I'm looking at, the ferritin level also is very elevated. That's very concerning for me. 2000. Um, I think that is one of the things that I'm like looking at, and what would be the cause of this changes in the lab findings.
Yeah, the same things that stood out to you stood out to me, and I think it's always a difficulty to try to label the CBC abnormality with precision because yes, you're right. Technically, this is pancytopenia. All the cell lines are down, but the question to ask yourself is there even more nuance in the CBC? So if you ask yourself, are there any parts of the CBC that are disproportionately affected? Is the white count lower than the hemoglobin, lower than the platelets? So you're right that this is pancytopenia. Would you say there is relatively equal disease in each cell, or is a specific cell line jumping out to you more than the other?
I think for me it more looks like the white blood cell.
Yeah.
That's the one that I feel
Right.
for me the one is more disproportionate decrease
Agreed.
compared with the other cell lines.
I completely agree with you, and I think for all of you listening, I think there's a lot of value in being precise about pancytopenia. And in our minds, when we say pancytopenia and we stop, what we're projecting is the impression that all cell lines are equally affected, proportionally so. It's the same thing though when you look at liver enzymes and you say, oh, okay, AST, ALT elevated. But yeah, that's true. But there's a lot of value in seeing what the ratio of the two is. So if I tell you AST, ALT elevated, but then I don't tell you that the AST is 2 times the ALT, how much did I leave off the table? And I think here is the same is true. This is pancytopenia with severe disproportionate leukopenia. In fact, this patient is now a medical emergency because they have a fever and they have neutropenia. So they have neutropenic fever. As an intern dealing with this, what does this trigger for you? What action steps have you been exposed to start to do for a patient with neutropenic fever?
I think one of the things that we've seen here is, of course, finding the cause of the neutropenia, but something that we do like immediate is admit this patient and start treating it empirically. We treat with antibiotic, treat the fever, treat the cause. Even we don't know where is the cause of the infection. We start with the empiric treatment. And then, of course, we send out all the infectious workouts, blood cultures, and respiratory culture in this case as well, respiratory panel. And then, and of course, in this case, we may, depending on the patient's clinical status, we may need even to admit to the ICU
Yeah.
for the management.
Neutropenic fever, as you said, is a medical emergency because the patient has no immune system and they're presumably fighting an infection. And so you're right. This is one of the rare instances where you start treatment before you know the diagnosis. But not all neutropenic fever is the same. The guidelines for the empiric treatment of neutropenic fever have to do when the neutropenia is as a result of chemotherapy. So chemotherapy-induced neutropenic fever, which the chemotherapy is causing the neutropenia and the neutropenia is causing the infection, is a very different world. And the reason for that is that the chemotherapy-induced disease not just affects neutrophils, but also causes the GI lining to be diseased. So you get mucositis and ulcerations. So the rate of gram-negative rod infections in those patients is very high. In this patient, many people would still treat them as neutropenic fever, but I want all of you to know that their risk of true gram-negative rod bacteremia is much lower than chemotherapy-induced neutropenic fever because the cause of their neutropenia is not necessarily a bad thing. It may be that their neutrophils are actually healthy and fighting an infection, and their GI lining is not affected by chemotherapy. So the risk of these things is very, very low. But often it's too scary for people just to say, oh, no, it's not chemotherapy, and so let's not treat it. So this is technically neutropenic fever, but the flavor of this neutropenic fever is much more, much less serious than that of chemotherapy-induced disease. And so I think we really have to proceed accordingly, though, and try to figure out where this infection is coming from and to ask yourself, are there any other clues? And I think the hypothesis of the spleen is further reinforced by the fact that this patient has such a prominent hematological fingerprint to their disease process. So knowing how the spleen is involved is going to be very key. But it's really hard, not to overlook the fact that this patient has a very high PTT. And I think whenever you see that, you should really worry about the patient having a bleeding diathesis, but also a thrombotic diathesis. And so here, on the CT scan, we'll have to see, does the patient have bleeding or does the patient have thrombosis? Because both those things can be tied back to a prolonged PTT. But let's not make sure we're analyzing the wrong problem, and this is a prolonged PTT due to heparin contamination, which is very, very common distractor and often leads to unnecessary workup. So yeah, Kirtan, what do you have next for us?
Yeah, and Rabi, since we have a little bit of time, maybe I can ask you guys because this question was there in the real
Yes.
time as well. That for a patient like this who had some headaches, who is looking sick, who has neutropenia, would you start empiric antibiotics? And second, would you proceed with LP, knowing that there is no neck stiffness or photophobia yet?
Yeah, that's a really, really good question. Thank you for bringing up these very practical questions. Hui, I think you already answered the first question, which is that you would give antibiotics because of neutropenic fever, and I think that's great. What is your reflection on LP? Yes or no?
Well, that's actually a trick question. OP because it doesn't have this like headache or sign of cranial elevated intracranial pressure. And I don't think at this point I would pursue LP yet, unless the patient develop more symptoms like changing in neurological symptoms, then I would think about pursuing. So I may be wrong, but at this point I think I'm gonna hold on the LP.
I think that, you really have to factor in one key variable, which is the patient, you have as much time to diagnose a disease as it's been going on. So if this patient came in with 1 day of high fevers, headache, sore throat, I think many more people would be inclined to do a lumbar puncture. But she's now coming in with 1 week of symptoms. So the idea that she has raging bacterial meningitis for 1 week is almost implausible. So I think we talk about a lumbar puncture as if it's a medical emergency in all people, a do or die decision, whether to do it or not. And the truth is, yeah, we may be overlooking temporarily a viral meningoencephalitis, a fungal meningoencephalitis, or an atypical meningoencephalitis. But overlooking that entity for a few hours or a day or two is totally okay. Why? Because the disease replicates very slowly. So the way I answer, do I need to do a lumbar puncture now, is to ask myself, now, not tomorrow, maybe tomorrow, but now, what is the probability of acute pyogenic bacterial meningitis? And in a patient who's been sick for I have the impression that a lumbar puncture is some sort of really cumbersome procedure. It takes 5 or 10 minutes. Now, the setup is difficult, and sometimes getting the CSF fluid is very, very difficult. But sometimes you should treat it like just getting a blood draw, like sometimes getting IV access in a patient can be very difficult, and you have to do ultrasound and so on and so forth. So for me, I think that what I would try to do is understand what's happening in the abdomen of this patient. And if that gave me an answer as to what the cause of her fever and her symptom complex is, I would happily defer an LP. But I wouldn't be losing any sleep over not doing an LP now, because the probability of pyogenic bacterial meningitis is not high. But if someone decided to do it for me, I wouldn't admonish them. I wouldn't say that's a bad idea. It certainly could be helpful. All right, Kirtan, Mike, to you.
Perfect.
How is this question answered in real life?
Yes, thank you so much. You guys did the good job about answering. We also had the similar thoughts, and I will tell you what eventually happened. So let me show the images first. Okay. All right. So I will show you two images. This is the first image.
Yeah. Any reflex thoughts on that image before we see the second one? Anything jump out to you?
Let's see. Is there
Take a
some
look at
kind of
the spleen.
inflammation? I think some kind of edema, and
Yeah.
I think the spleen is bigger than it's supposed to look. So maybe some spleen enlargement with some edema.
Yeah. Yeah. It's hard for me to tell if the spleen is big or not in this single slice. If I had to guess, I would say it's not too big, but I might be wrong. And then you're right. You see two areas of hypodensity, especially the one that is more posterior, looks very wedge shaped. And so I think that we might be seeing some wedge-shaped hypodensities in the spleen. You have another image, Kirtan, or?
Yes,
Yeah.
yes. I will share another image. This is also good one. So yeah, you guys got it. You can see all this, almost 1, 2, 3, about 4 of them.
Fascinating. Can I ask Kirtan, the spleen size doesn't look too big to me. Is
Correct.
it big or no?
You are right. Yes,
Okay.
you are right. So the official radiology read said that firstly in the lungs, since this person presented with productive cough, sore throat, we wanted to make sure that there is no parenchymal foci or pleural foci of infection. So CT scan didn't reveal any pulmonary embolism, normal lung parenchyma with stable chronic changes, which means that there were calcified granulomas here and there. There was bronchiectasis in upper lobes, but no new granulomas, no new consolidation, nothing like that. Mildly enlarged spleen, so they say barely like 14 centimeters, so at the cusp of being enlarged, but not clearly enlarged, with multiple wedge-shaped hypodensities, concerning for splenic infarct. No lymphadenopathy anywhere in the belly or chest, and no hepatomegaly. So at this point in time, as you could imagine, that patient was really, really sick. She was getting diaphoretic as well. She was becoming tachypneic. She required some oxygen support as well. So extensive infectious workup is sent. So I will give you all of that. So blood cultures, fungal cultures, sputum cultures, urine cultures, all negative. Respiratory viral panel negative. HIV, hepatitis A, B, C, syphilis, negative. And we also embarked on the journey of figuring out this splenic infarct. So eventually we got urine histoplasma, brucella, blastomycosis, legionella, cryptococci, EBV serologist, CMV serologist, VZV serologist, all of them turned out negative. And given that this patient has history of autoimmune disorders, we got some autoimmune serologists which showed ANA being more than 1:160 and double-stranded DNA being 17. And last time the serologists were checked, they were negative. So ANA was negative, dsDNA was negative. Now they are positive. Rheumatoid factor elevated at 1,000. Anti-CCP elevated at 300. Complement levels C3 and C4 was normal. And peripheral smear was unremarkable for any abnormal sense.
Excellent, Kirtan. Wow, fascinating. Well, yeah, I think sometimes, especially you might remember last year before you were an intern, a case like this can get a little overwhelming. So maybe for people who are listening, do you mind just sharing what your problem representation is so far? How is this case kind of condensed in your mind? What would you say?
I would kind of say that this is a 63 years old female with some new onset of fever, upper respiratory symptoms, and left upper quadrant pain, with some abnormal lab finding, pancytopenia, elevated inflammatory markers, and abnormal finding in the CT scan that could represent splenic infarct.
Beautiful. Yeah, beautiful. When you become PGY 11, uh, I'm so old. Oh my gosh. When you become a PGY 11, you take it even further and you say, this is splenic infarct with fever,
Yeah. Mhm.
leukopenia, and a prolonged PTT. And you see how I'm ignoring the respiratory symptoms, ignoring the duration of disease, probably at risk. But with time, you start to see what are the things that are the most narrow differential diagnosis. And I think here, the splenic infarcts have a very, very narrow diagnosis. Not very narrow, but fairly narrow. So I'm curious, how are you thinking about these splenic infarcts?
Yes, with the splenic infarct, I'm wondering if there's any causes of thrombosis in this patient, either because can be infectious, but it looks like his infection workup has been almost negative. And of course, Maddie just gave us like a very nice reflection about splenic infarct, talking about the pumps, pipes, and plasma, some of the causes of the splenic infarct. So, for example, for pumps, we think about like endocarditis, one of the causes, or like Brucella, Bartonella. So yeah, so I'm just curious, and what would be the main cause, if it's an overproduction or it's a hyperproduction of the spleen, and of course, and see on physical exam if there are any um um splenomegaly as well. That's gonna help us to go to the diagnosis.
Yeah, outstanding. I think about it just like the way you do, and I'm glad you were able to see Maddie as a refresher. How medicine is a small world when you start to realize that all these things come up a lot. I think if I may share an analogy about splenic infarct to make it all easier for all of you, I would love for you to think about a splenic infarct just like you think about a myocardial infarct. Because I think we all recognize that a myocardial infarction can happen either because there's a sudden drop in arterial supply to the myocardium in the form of ACS, but you can also infarct and cause death of your myocardial cells from a rapid increase in demand. So if you have a stable coronary artery disease and you have severe sepsis, you're going to infarct some myocardium, but the issue is demand, and the spleen can infarct for the same reason. The first question to ask in a patient with splenic infarct is, do they have splenomegaly? Because if you have a patient who has both a splenic infarct and splenomegaly, the infarcts are meaningless, almost meaningless. Why? Is because the spleen is getting so big that it's often auto-infarcting its own vessels. And so if you're trying to solve splenic infarct with splenomegaly, you should just ignore the infarct and focus on what causes splenomegaly, because the infarcts are just a consequence of the rapid enlargement of the spleen. Now, there's a couple of exceptions. You can have a splenic vein thrombosis that can actually cause splenomegaly from passive congestion and an infarct. And you can have endocarditis cause splenomegaly and infarct. But most of the time, it's really an increase in demand that's causing the infarct. So, Hui, it's really powerful here that this patient is having a lot of splenic infarcts, 4 or 5, with very little splenomegaly. This tells you it's very unlikely to be an increase in demand and very likely to be a thrombosis or a drop in supply. So here you ask yourself, what problem am I trying to solve? You're trying to solve a thrombotic occlusion of the splenic arteries causing infarcts, not an increase in demand. So the pump pipe plasma is exactly the right schema to use. And so now that we've really come to the conclusion that we're solving a thrombus problem, how is your mind thinking about thrombosis plus a prolonged PTT? How does that intersection, what does that bring out for you? Weird, right? The patient has high PTT, they should bleed, but instead they're clotting. What's that about?
Yeah, I was thinking about that as well. I'm not sure if there is some kind of component like lupus in this patient, some other immune that could explain that. Because it's true. Usually it's more if there's a prolonged APTT, it more is bleeding. And that's
Yes.
not exactly what we're seeing. It's more an infarct or thrombosis. So I'm thinking about if there's any hypercoagulable state in this patient that is causing this instead of that can
Yes.
explain
100%.
the lab findings.
Yeah, whenever you see thrombosis and a high PTT, you have to think about APLS, antiphospholipid antibody syndrome. And the reason the PTT is high is because there are antibodies against the phospholipids that prevent the conclusion of thrombosis in vitro in the test tube. But in real life, the patient's hypercoagulable. And APLS often occurs in patients with autoimmune disease, usually lupus, but can occur in others. And that's, I think, where the serologies are very, very helpful, And here you have a positive ANA and a positive dsDNA. As you said, you have to worry about lupus, especially in a patient who also has pancytopenia with disproportionate leukopenia, very characteristic of lupus. And you might ask, well, why would this patient get lupus? And the answer is very simple. They have an autoimmune disease. If they have one autoimmune disease, they can get another one. But a more complicated answer is to realize that the journey between one autoimmune disease and another autoimmune disease can be a direct line. So if you have one autoimmune disease, you can get another, but unfortunately, treatment can also beget other autoimmunity. So there's an entity called TNF alpha induced lupus, where patients with RA who are on chronic TNF alpha like adalimumab can get a lupus picture. Curiously, the lupus picture in these patients tends to be milder and actually often only involve the surface. So they get arthralgias, rashes, so on and so forth. So I think that here we're starting to move away from infections and focus on autoimmune disease by virtue of the possibility of APLS and the possibility of drug-induced lupus in this patient. And so I would be worried about those things. But I think we have to go back to her headache, right? And her fevers. So Hui, now that you know she has splenic infarcts and you also know she's having a headache, how are you thinking about her brain? What could be happening in her brain?
I feel very concerned about if could be some type of stroke there as well. Because if she is already having infarct in the spleen, one of the organs, and she's
Yeah.
having changes in mentation, headaches, I will go ahead to do actual
Yeah.
CT scan and see if there's any type of stroke, ischemic or hemorrhagic that I can see. And then it's gonna change what will be the management of this patient.
100%. Yeah, I think looking back and now I'm less inclined to get an LP, more inclined to get CT/MRI for this patient's brain. And at the same time, I think another key test will be a transthoracic echo to see, is there a focus in her heart that's causing all this? So very, very sick patient, and hopefully we can get some clarity soon. All right, Mike to you, Kirtan.
Perfect. So friends, since we are nearing the end, what I will do is I will give you all the data, what happened, and then I will leave it up to you guys to reflect, and then I will share the closure of the story. So flow cytometry, as I said, was obtained because there was concern that could this be some sort of myeloid neoplasm going on. So the flow cytometry was unremarkable. The fact that the person had neutropenia, we also obtained PNH serologist because sometimes the way PNH manifests is very unusual. And nowadays, the standard of care in hematology world is that whenever somebody has unexplained cytopenias, any cell line, you should get PNH serologist because PNH is actually a disorder of stem cells and not just of red blood cells, because the CD55-59 is on all the cells. So we obtained the PNH workup, which was also unremarkable. Regarding what Rabih and Hui Ting and everybody in chat was alluding to, that what's the deal with these infarcts, right? So we obtained the extended workup for endovascular infections, which could go to the spleen. So we obtained the Bartonella serologies, which were also unremarkable, both Bartonella, Hensley, and Quintana. We obtained the Q fever serologies, unremarkable. A repeat quantiferon was obtained, answering the Jess question in the chat, and which is a valid question, that you are on TNF-alpha inhibitor. Can you have reactivation of TB? Probably not in the lungs, but somewhere else in the body. And maybe that is causing some splenic issues. So we obtained the repeat quantiferon, repeat AFB cultures and sputum, which was unremarkable. And there was no evidence of ascites or any kind of TB in the peritoneum. We obtained the transthoracic echo, which was unremarkable. No evidence of infectious or non-infectious vegetations. The valves looked good. And we obtained the CT head, and CT head was unremarkable. And as you could imagine, although I agree with what Rabih and Hui Ting said, that it's 1 week of symptoms, so probably not meningitis, at least not bacterial meningitis, but still eventually she ended up getting CSF analysis, which was completely normal. Nothing grew from it, normal cell counts, normal protein. So your hunch was correct. And regarding the APTT, so first and foremost, we did the mixing studies. So mixing studies didn't correct APTT, so which means that there is some sort of inhibitor. And finally, we obtained the lupus anticoagulant, which was positive, and we obtained it kind of like eventually, I'm saying 12 weeks apart, which is the criteria that you need to check these antibodies 12 weeks apart to make sure that first one was not false positive. So lupus anticoagulant was positive on 2 occasions, 12 weeks apart. Cardiolipin beta and anti-beta 2 glycoprotein antibodies were negative. And ANCA was obtained, ANCA was also negative. And since this patient had neutropenia, we are also wondering that what kind of infections you can get if you have neutropenia. And could that be causing some sort of disseminated infections everywhere? So one of the infections which can happen when you are severely neutropenic is Candida. Now, usually, as Rabih said, that this is more common in people who get neutropenia from hematologic malignancies or stem cell transplants because the neutrophils are not good. But still, we obtained the 1,3-beta-D-glucan repeat fungal cultures. So 1,3-beta-D-glucan came back negative. Repeat fungal cultures were also negative. And at this point in time, what happened was that within 1 week, the patient's WBC went from like 1.7 on admission to like 3.9 on discharge. Platelet counts normalized. Hemoglobin came to the baseline. So the team said that the patient has been on adalimumab for last few weeks. So maybe adalimumab, we know it can cause neutropenia, and it could have caused some autoimmunity, causing all these LA antibodies, ANA positivity. And the patient was discharged to be followed up in the outpatient setting. And I would leave it up to at that point, and then I will like to hear from you guys that what was your thought. And of course, this is not the final diagnosis. So guys, don't worry. I am not going to give you anticlimactic ending. I will give you what happened in the end. But I want you guys to tell me that what would you do in practical time, that this is what happened. The patient was eventually discharged because her fevers went away, her symptoms improved just with like Tylenol or something, symptomatic improvement, nothing else.
Yeah, what do you think, Hui?
No, that is interesting how the patient kind of recover from the neutropenia and now is um the treatment is just like Tylenol. I mean, in real life, if we consult Hemont on this case, I think they would just say we're gonna follow up as outpatient. That is something that they would say, but I don't know. It is for me. I still think about maybe some like we mentioned before, APLS, lupus. That's one of my big differential in my head. But yeah, I don't know, Robbie.
Yeah, I
What do
mean, I
you
think that,
think?
yeah, I'm right there with you. I think I'm very glad that the patient got better in many ways, but let's remember that she had strokes of her spleen, and if she had strokes of her brain, we would never be comfortable without discharging her with some sort of treatment to prevent those strokes from happening, because the truth is they'll keep happening. And so I think for me, if I were taking care of this patient on an island by myself, I would probably start treatment for APLS because the patient meets criteria for APLS. She has thrombosis, and she has a lupus anticoagulant. Now, a lupus anticoagulant, the three main APLS serologies, lupus anticoagulant, beta 2 micro, like beta 2 glycoprotein and anticardiolipin antibodies are all the same. All three of them are APLS associated, but their ability to predict thrombosis is very different. The risk of thrombosis in lupus anticoagulant is very, very high, much higher than the other two. And so when you have a persistently positive lupus anticoagulant and thrombosis in a patient with autoimmune disease, I think treatment for APLS is probably something to really strongly consider. And for me, I would probably start it. And the gold standard treatment is with warfarin. And so for me, I think I would be inclined to initiate warfarin with a bridge, of course. Um, and I would worry most that this patient has APLS with or without drug-induced lupus. That would be my main concern. The thing I think we could be missing is the possibility that there is transient APLS serology elevation from a spontaneously resolving infection, but this patient got better without treatment of a very specific infection. So I think that would be what I would be worried about the most.
Perfect. All right, friends. So, Rabih, do you want me to give the closure?
Yeah, please.
Perfect. Perfect. So this is what happened. And now this is one of the aspects of medicine which I'm most excited about because these all developments came in last few years. So here is the deal that my team was saying that I was in hematology at this time. So our attending and everybody was saying that TNF-alpha inhibitors can cause neutropenia. It's actually common, neutropenia and thrombocytopenia. So maybe this is just from that. And now that we stopped the adalimumab and we didn't give the next dose, which was due at this time, maybe the neutropenia is recovering. And I said that definitely it's a valid hypothesis. But the only part which I was not satisfied with, or I was kind of grappling with, was that how would TNF-alpha inhibitors cause splenic infarct without splenomegaly, as Rabih explained. Now, of course, APLS can cause it, but then you start wondering that what would cause APLS serologies to be positive? Is this primary APLS in a lady at this age? And what about those ANA and dsDNA serologies which were not present before? And why it would come all of a sudden now? And she doesn't have any classic symptoms of SLE anywhere in the body. Then what to make with those serologies? And here is the part which comes in, that what about any underlying malignancies which can cause false positive autoimmune serologies? So we always say that, for example, angioimmunoblastic T-cell lymphoma tends to cause false positive serologies. And similarly, there is one more disorder, which, as you guys mentioned in the chat earlier, people can have LGL, which is large granular lymphocytosis, or large granular lymphocytic leukemia, which can also cause false positive serologies. Now, one more important aspect is that if we are going down the rabbit hole of this being a malignancy, we have to explain that why this person does not have hepatomegaly, why this person doesn't have lymphadenopathy anywhere, because usually that's what we think, right? That if you have hematologic malignancies, you should have lymphadenopathy. So there are some specific hematologic disorders which do not cause lymphadenopathy or have paucity of lymphadenopathy. So for example, in B cell realm, hairy cell leukemia and splenic marginal zone lymphoma do not tend to cause lymphadenopathy. In the T cell realm, hepatosplenic T cell lymphoma and LGL leukemia do not tend to cause lymphadenopathy. And hepatosplenic T cell lymphoma is important because TNF-alpha inhibitors increases the risk of this lymphoma by massive amounts. It is one of those unique lymphomas which is not seen in nowadays, but it is only seen in people who are on TNF-alpha inhibitors. So I was also considering that could this person have hepatosplenic T cell lymphoma? But that lymphoma usually does not tend to cause this many autoimmune serologies. So what I was thinking was that just like we have pure red cell aplasia, we have something known as autoimmune neutropenia. So the first aliquot which Rabih discussed, that maybe this person's neutropenia is out of proportion to all other cell lines, and TNF-alpha inhibitor should also cause thrombocytopenia. So I was thinking that could this person have autoimmune neutropenia? And almost all the people who have autoimmune neutropenia tend to have clonal expansion of LGL cells in their bone marrow. So it is known as large granular lymphocytosis. In some people, this clonal expansion crosses the threshold and you enter the world of LGL leukemia. So, and now, what about splenic infarcts? So if your spleen is not enlarged and still your spleen is infected, which means it is possible that maybe there is rapid proliferation of myeloid cells within the splenic periphery, and maybe these myeloid cells are in the blood vessels itself. So which means we are dealing with malignancies which are not just infiltrating the spleen like a random malignancy, but they're infiltrating the blood vessel itself, causing secondary vasculitis. So that's why I was very concerned for LGL leukemia in this person. So I told my team that I want to do some testing, and you know how it is, right? That they want to follow in the outpatient setting. They were not convinced. So eventually I got hold of the primary team and I told them that how about we send some testing from the blood to convince the team more. So now, as we know that over the years, we have realized that almost all the autoimmune disorders and all the malignancies have underlying somatic mutation, which is driving everything. So the classic example is the VEXAS syndrome. We know that people can have UBA1 gene mutation, which drives the myelodysplasia and also drives the autoimmunity in terms of vasculitis, Sweet syndrome, polychondritis. Similarly, in people with rheumatoid arthritis, they found out that almost all the people with RA who end up developing either Felty syndrome or LGL leukemia, almost all of them have a mutation, which is known as STAT3 mutation. So STAT, as we know, stands for signal transducer and activation of transcription 3. So what I told my team was that, hey, how about we send the panel of next generation sequencing from the blood first to see if there are any somatic mutation which can guide us further. So the primary team was kind enough, they agreed. So they went ahead and sent the NGS, and NGS came back positive for STAT3 D661Y gain of function mutation. Now, this is also important because if you think about it, STAT3 is one of the molecular signaling pathway. And the way STAT3 works is you have to undergo dimerization of the two STAT molecules before you can activate the underlying transcription. So for dimerization to happen, you need to phosphorylate the initial STAT molecule. That's why kinases are very important. Now, in order to phosphorylate, you need a domain where you can phosphorylate. So that domain is known as SRC homology to SH2. So what happens is these mutations, D661Y, is in this domain of the STAT3, which undergoes phosphorylation. So when this mutation happens, that domain becomes more hydrophobic. So you allow the two STAT3 molecules to dimerize on the cell surface, and they start become constitutively active, which means they don't need any kind of stimulation. They start working like crazy. And once the STAT3 starts functioning, you drive the oncogenic transformation to leukemia. And at the same time, STAT3 also exists in all the immune cells. So you start forming the autoantibodies, you start driving the autoimmunity. So people with STAT3 can have cytopenias, they can have autoimmune hepatitis, they can have primary biliary cirrhosis, they can have interstitial lung disease. So all the autoimmunity which you can't figure out is all driven by this one domain of STAT3. So now what happened that since the NGS came back positive, and now I reached out to hematology again in the clinic that, hey guys, I sent the STAT3, it came back positive. Now can we consider bone marrow? So they were like, okay, Kirtan, we will give it to you that now we have reached the threshold, we will take it. So they eventually did the bone marrow, and bone marrow just came back like 5 days ago. So the bone marrow did show the expansion of CD3 positive, CD8 positive, and TIA, which is T cell intracellular antigen positive LGL cells. And usually this kind of triple positivity, CD3, CD8, TIA, is not seen in fatty syndrome. It is more suggestive of LGL leukemia. And which also explains that why there was splenic infarct, because maybe it was the LGL leukemia which was infiltrating the blood vessels of the spleen and causing out of proportion infarction to the splenomegaly. So this was the final conclusion. So my takeaway home message for everyone is this, that in last few years, we have realized that how all the somatic mutation drives everything. So if you have suspicion, you can get the somatic mutations ahead of time. And in fact, the somatic mutations are so powerful that people say that this person could have normal bone marrow because STAT3 precedes the oncogenic transformation by months and months. So this person could have STAT3 mutation going on for last 1 year, and only now she is having the evidence on bone marrow. So bone marrow could be clean as well, but the fact that there is STAT3 mutation itself means that that is enough to cause the cytopenias, that is enough to cause all the autoimmunity. So in this person, eventually we treated the LGL leukemia, and the way you treat LGL leukemia is you take care of the underlying autoimmune disease. So standard treatment is you can give methotrexate, you can give cyclosporine and cyclophosphamide. So all of that was given, and eventually all the autoimmunity serologies went away. Her splenic infarct calmed down, her symptoms improved as well, her cell counts stabilized and everything. So that was the final conclusion.
Absolutely fascinating. Thank you so much, Kirtan, for all of that reflection and the and strengthening of the connection between RA and LGL. Hui Ting, what are you thinking?
Oh my God, I think I just got a lecture of this. I was so, impressed about your dissection, Kirtan. I mean, I never seem to be stop impressing me with all your clinical reasoning. This is like, I think I have to read more about this. After you lecture, I think I have to do more of the somatic mutation and all. I don't know. I'm out of my words. Thank you for the teaching. It was really amazing.
Yeah, no, I'm right there with you. I think that this is a very, very powerful reflection of what underlies all of this. And I think it really raises a lot of questions about what what the rheumatoid arthritis is to begin with. And I think, as Kirtan knows, when you start to read about the relationship between rheumatoid arthritis and LGL cells, it gets very, very complicated. And I imagine that all the people who are invested in this patient had a lot of concerns about pursuing this hypothesis because you'll find that in many, many patients with rheumatoid arthritis, they have what is considered asymptomatic expansion of LGL cells. And I think the difficulty in pursuing this hypothesis is to ask yourself the question that comes from the knowledge that about 50 to 70% of patients with rheumatoid arthritis will have these cells. And so what do they mean is often very tricky, because sometimes they mean nothing. But as we saw today, sometimes they mean very, very severe risk of a life-threatening process. And I think if you look back on this case and you see, and you ask yourself, well, what am I really trying to accomplish here? What is my goal by treating this this patient very seriously? And I think you might say, oh, my goal here is to make sure the patient doesn't have more thromboses, right? Because that's ultimately what you're caring for. And so I am very struck by whether anticoagulation is the way to find therapeutic benefit, or chemotherapy is the way to find therapeutic benefit. So Kirtan, I'm really curious to ask you, how are we attributing causality here? How are we distinguishing between these clots being APS-induced thrombosis versus the LGL infiltration? How is that being done?
Yes. So no, I agree with Rabih, and we also discussed this with our hematologist, and they did say that usually when you have leukemia, which causes transient autoimmunity, the antibodies which are produced, sometimes they are just there, like they are not causing any damage to the body. But for APLS antibodies like this LA, it could be actually driving the clotting. But since the LA itself was driven by the underlying neoplasm, if you take care of neoplasm and LA becomes negative, then you don't need lifelong clotting, any kind of treatment for that. But you are right that while she was having splenic infarct, she was actually discharged on 3 months of rivaroxaban. And you could imagine that, as I said, that LA was positive 12 weeks apart, but patient was not in the hospital for 12 weeks. So we presumed that whatever this APLS is coming from, either primary or underlying LGL leukemia, we need to treat it. So we did send the patient on rivaroxaban, but after the 3 month, eventually all this STAT3 stuff came back, and eventually the bone marrow returned positive, and then we treated her effectively. There were no more infarcts. She was stable. So eventually, after I guess 4 month mark, we stopped the anticoagulation. But no, you are right that maybe LGL was contributing to some extent, but it was APLS as well. Definitely.
I love that. I'm really struggling with them, and I'm so glad we have some time before we end. I'm personally struggling with how to attribute causality to the LGL cells here. And I'm curious, what did you learn from this case about distinguishing between the benign expansion of large granular lymphocytes in RA and the development of a syndrome related to it? So when you said earlier, you're saying the patient crosses the threshold, right? Because realistically, there's a possibility that she had these cells in her bone marrow 5 years ago, 10 years ago, 20 years ago. How do we know that these cells are causing the problem? You know what I mean?
Correct. Yes, yes. So definitely, Ravi. And in fact, over the years, like I will share this article in the group, that this STAT3 article which came in NEJM and Frontiers in Immunology. So what they said is that some people believe that Felties and LGL exist on a continuum. But some people also say, and eventually that hypothesis has been refined, that many people with Felty syndrome do have LGL expansion, and that LGL expansion could be clonal if you do the immunophenotyping. But those people do not have STAT3 mutation. But if you have STAT3 mutation in your LGL cells, then that's the telling of LGL leukemia. So in fact, in this case, what happened that eventually the peripheral blood smear showed NGS positive for this. And one more part which I didn't mention is that there is something known as VAF, which stands for variant allele frequency. So it means that whatever mutation you are detecting, what's the proportion of that mutation in your myeloid stem cells? So for example, I could have STAT3 VAF, which is 0.01%, which means it was barely picked up. Then you can't say that, oh, that minute amount of STAT3 mutation is causing the autoimmunity in the whole body, right? So if your VAF exists a certain threshold, you say that, hey, this is not by chance. This cannot happen randomly in any RA person, but this is LGL leukemia. So in this case, the VAF was very high. It was like about 20%. Usually in people with RA, even if they have VAF of stat 3, it is usually less than 1%. So since that VAF was so high, when the pathologist saw that, pathologist told that, hey, this is very concerning, that whoever sent this NGS on blood did something good, that because we would have never sent NGS, and without that, we wouldn't have known this. So then they obtained the bone marrow, and in the bone marrow, the stat 3 again came back positive with high VAF. So if your STAT3 is positive with high VAF, then it is not seen in Felty syndrome as per the current literature, and it is very telling of LGL leukemia. And the fact that after treating this, we repeated the bone marrow and those clonal expansions went away. So usually if it's just Felties and RAs and you are getting enough treatment for that, the clonal expansion should not be there. But it's the fact that it was there, the hematopathologist thought that this was real leukemia, which caused all of this. And even the ANA, DSDNA returned negative eventually, and patient was stable. So that was the hypothesis, that because of the high VAF and the STAT3 being positive, which is not seen in Felties, the causality was established.
Fascinating. That's outstanding. Thank you so much for that clarity. And then how are you examining the relationship of this leukemia with the rheumatoid arthritis? Do you think that she's had LGL leukemia for a long time causing her RA, or her RA? Like how are you putting those two things together?
Right. I think that first the RA came because the patient's neutropenia just started in last few months, because usually that's the one of the first sign of LGL, that, as I said, that even bone marrow could have been normal, completely normal, no clonal expansion at all. But the STAT3 mutation itself can drive neutropenia. That's why nowadays people are saying that even if somebody doesn't have RA, let's say tomorrow I develop autoimmune neutropenia, they said that you should check for STAT3 mutation, because people who have autosomal dominant STAT3 gain of function mutation at young age, so those people get cytopenias at the age of 1 year or 2 years. So, and it's the same STAT3 mutation, D661Y, which is in this homology region. So people are saying that in people with RA, they are at increased risk of this mutation, and eventually that causes LGL. That's why RA is linked with LGL more. But even random person can get out of the blue same mutation, and they will also have neutropenia. So I think first the RA came, and then the STAT3 came, and then it caused the LGL. And now both STAT3 and LGL went away after the treatment. And now what we are left with is just RA.
Fascinating. Absolutely fascinating. This is so insightful. It really gives me a lot of clarity about how to understand the relationship between these two conditions. And fundamentally, I think what you're teaching me is the idea that a STAT3 gain of mutation, a STAT3 mutation is the fundamental underpinning here, and that the amount of mutation is really crucial to attribute causality to this disease, and that patients with RA are different from patients than other patients only by the chance of getting this mutation, but anyone is vulnerable to it. Is that a fair summary?
Yes,
So
I
yeah,
agree.
that's why I
Correct.
asked you. We needed 10, 15 minutes of kirtan at the end to be able to get all the juice out of it, because none of us can do it justice. So thank you so much for that lecture on LGL leukemia. And I wonder how the hematology attending felt after receiving a lecture from you. But okay, thank you so much, Kirtan. Hui, do you have any questions for Kirtan that you wanted to clarify before we learn from Patricia?
Um, Actually, not at this point, but I will follow up on that as
Okay,
well. I
sounds
think
good.
it's true, because I feel like I was just in silence here because I feel like I'm getting a lecture, which is good. This is a good learning. It's always good to learn from Curtin. I knew that there was not be just an easy case, but
Yeah.
there's a lot of learning. So yes, I will get back to you with more questions, but none at this time.
Amazing. All right. Well, Mike, to you, Patricia, you have the feel free to summarize everything short of the LGL lecture, because I think that stands on its own. And Mike, to you, my friend.
Wow, Keaton, thank you for bringing this case. I hope I got some few things. I hope it will be enough. Even if it's not enough, I don't know, maybe text you for you to explain more. And so what have we learned for this case? And we started with the patient with our history, and then it was important for us to know the timeline of the presentation and why the patient is coming now. We had a discussion about the fever. We had this mnemonic IMAD, which stands for infection, infection like respiratory or GI infection, malignancy. A stands for autoimmune drugs, and D stands for drugs like we need to check the history of polypharmacy, which can be which we often missed. So it's important to ask about the medication that the patient is taking. And E stands for endocrine. We had a complaint of left upper quadrant pain. It can be caused by gastric or pancreatic disease. But when we have left quadrant pain plus inflammation, it's important to think about the spleen, which can be affected by endocarditis or malignancy. And it's also important to think about the pleuropulmonary process. Talking about the spleen, we don't always have the CT scan available like right away. So we can get information on the CBC. The CBC can, since the spleen is a hematological organ, the CBC can help us to have more information about the spleen status. We talk a lot about spleen infarct, and Dr. Rabih said that we need to think about spleen infarct like we think about myocardial infarct. So is it a decrease of supply where we will have thrombosis, or is it an increased demand, which is usually associated with splenomegaly? When we have, in this case, we had a thrombosis, we had thrombosis and prolonged PTT, which is usually not common. Usually prolonged PTT is a state of coagulation, but here we had prolonged PTT and thrombosis. So it was important for us to think about APLS, which is often associated with autoimmune disease like lupus. Autoimmune disease can be acquired from other autoimmune disease, like having one autoimmune disease predispose you to other autoimmune disease. And medication also can make you acquire some autoimmune disease like TNF-alpha inhibitor. In this case, we talk more about do we need to treat or not. Like in this case, we had APLS syndrome. We had APLS, so thrombosis. We had positive lupus anticoagulation. So we can treat. Like the discussion decided it's best if we treat, and if we decide to treat, we need to treat with warfarin. Also, some autoimmune disease can be acquired, but it can be acquired, and we have like false APLS in case of malignancy, like in this case where we had LGL leukemia. We talk a little bit about pancytopenia, and it was important for us to know that if the pancytopenia is relatively equal or disproportionate. So we need to look more closely at the cell line and see if we have more, if one cell line is more decreased compared to the other. We talk a little bit more about fever plus neutropenia, which is usually neutropenic fever, which is an emergency, which is a medical emergency. We need to treat right away, hospitalize the patient, treat with empiric antibiotic, do blood culture, respiratory culture, and it was noted for us that it can be caused by infection. Neutropenic fever can be caused by severe infection, chemotherapy, and like in this case, some autoimmune disease. And we learn also that rheumatoid arthritis is usually associated with LGL leukemia. And yes, LGL leukemia, those LGL cells are present inside people with rheumatoid arthritis. So it's not uncommon to find them, but it can get worse and cause neutropenic autoimmune disease, which put the patient at high risk for thrombosis, like in this case where we have splenic infarct. And what was also interesting, the last point, was a high PTT, which can be caused by which can lead to bleeding or thrombotic event. Yes, so that's all I had for you today. Thank you so much for the discussion, Dr. Rabih Hui Ting. It was amazing.
I don't think
Hilton, go.
I
Okay.
don't think people can really appreciate how difficult the task of summarizing such a complicated case is, and I think you hit the nail on the head. Thank you so much, Patricia. That was really, really well done. What an amazing hour. Thank you to Rahul for scribing such a complicated case, to Patricia for teaching again. Always a pleasure to see you here. And I told you we would fall together, and together we fell. But we're picked up by outstanding teaching from Kirtan at the end. So have a wonderful day, everybody. And just so for those of you who will watch this on YouTube, I encourage you all to tune in live tomorrow because you'll have the treat of yet another Kirtan case. Look forward to it. Bye, guys.
Bye.